Preoperative risk factors for postoperative deep vein thrombosis, DVT. Deep vein thrombosis, DVT, is a significant concern in surgical patients, as it can lead to life-threatening complications such as pulmonary embolism, PE. Identifying preoperative risk factors is crucial for planning appropriate prophylactic measures. 1. Patient-specific factors. 1. Age. Risk increases significantly in patients older than 40 years. The risk doubles with each subsequent decade. 2. Obesity. Increased intra-abdominal pressure and reduced mobility contribute to venous stasis. 3. Previous history of DVT or PE, strong predictor of recurrence. 4. Hypercoagulable states, includes inherited thrombophilias, e.g. factor V Leiden mutation, protein CS deficiency, antithrombin 3 deficiency, and acquired conditions, e.g. antiphospholipid syndrome. 5. Cancer. Active malignancy and cancer treatments, chemotherapy, surgery, increase prothrombotic states. 6. Hormonal factors, use of oral contraceptives or hormone replacement therapy, pregnancy or postpartum state. 7. Immobility. Bed rest or limited mobility preoperatively contributes to venous stasis. 8. Chronic medical conditions, includes heart failure, chronic kidney disease, and inflammatory diseases, e.g. inflammatory bowel disease, lupus. 2. Surgery-related factors. 1. Type of surgery. Orthopedic surgeries, e.g. total hip knee replacement, hip fractures, carry the highest risk. Major abdominal, pelvic, or thoracic surgeries, especially cancer-related surgeries, are also high risk. 2. Duration of surgery. Procedures lasting more than 2 hours increase risk. 3. Trauma surgery, associated with systemic inflammation and immobilization. 4. Laparoscopic procedures. While less invasive, the pneumoperitoneum can impair venous return. 5. Use of general anesthesia leads to prolonged immobility and venous stasis compared to regional anesthesia. 3. Preoperative conditions. 1. Dehydration. Hemoconcentration increases thrombotic risk. 2. Prolonged immobilization pre-surgery. Patients confined to bed due to injury or illness preoperatively are at heightened risk. 3. Venous insufficiency or varicose veins. Chronic venous disease predisposes to thrombosis. 4. Sepsis or infection. Systemic inflammation and hypercoagulability are contributory factors. Prophylaxis for postoperative DVT. Preventing DVT is essential in reducing postoperative complications. Prophylactic strategies include pharmacological and mechanical methods tailored to the patient's risk level. 1. Risk assessment. Use validated tools like the Caprini risk assessment model to stratify patients into low, moderate, or high risk. Consider individual patient factors and type of surgery when selecting prophylaxis. 2. Pharmacological prophylaxis. Anticoagulants, low molecular weight heparin, LMWH, e.g. enoxaparin, most commonly used, reduces DVT and PE risk with a good safety profile. Unfractionated heparin, UFH, used in patients with renal impairment or high bleeding risk. Direct oral anticoagulants, DOACs, e.g. rivaroxaban, apixaban, effective in certain surgeries like total joint replacements. Warfarin, reserved for select patients due to slower onset and need for monitoring. 2. Aspirin, low-cost option for select low to moderate risk patients, especially in orthopedic surgeries. Mechanical prophylaxis. 1. Intermittent pneumatic compression, IPC, devices reduce venous stasis by mimicking the calf muscle pump, often used in combination with pharmacological agents. 2. Graduated compression stockings, GCS, enhance venous return but are less effective as monotherapy. 3. Early mobilization, encouraging movement as soon as possible postoperatively reduces venous stasis. 4. Leg elevation, improves venous drainage. Combined prophylaxis. High-risk patients often benefit from combined pharmacological and mechanical strategies. 5. Duration of prophylaxis. Low-risk patients, prophylaxis typically limited to hospital stay. Moderate to high-risk patients, continue prophylaxis for 10 to 35 days postoperatively, especially after orthopedic or cancer surgeries. 6. Special considerations. Balance between thrombosis prevention and bleeding risk, particularly in patients with contraindications to anticoagulation, e.g., active bleeding, high-risk surgeries. Use of inferior vena cava, IVC filters in select high-risk patients where anticoagulation is contraindicated. Conclusion. Preoperative identification of DVT risk factors is crucial to tailoring prophylaxis strategies. Multimodal prophylaxis, incorporating pharmacological and mechanical methods, remains the cornerstone of prevention in surgical patients. Close monitoring and adherence to guidelines ensure optimal outcomes while minimizing risks.